Good evening, folks. I'm Mike DiFilippo. I'm one of the SAEM board of directors. I'm also hosting the webinar for tonight. This is the Crafting Your Chart Medical Decision Making webinar. I can't imagine you're probably signing up for more webinars on a Thursday night, so this is probably the one you were signing up for. We'll get started just shortly, just waiting potentially for a few stragglers. In the meantime, I'll introduce our panelists. But first, I just want to say thank you to Juana and the rest of the SAEM staff for taking their time to come host this webinar, as well as all the post-editing that'll go into this. First up is Dr. Mark Corrado. He's an assistant professor of emergency medicine at New York Presbyterian Weill Cornell Medical Center. He also teaches the residents in our cohort how to craft your chart and really what goes on in a chart. We'll be focusing on the MDM section today. The other person on the panel is Dr. Danny Hausner, who's one of my co-chief residents of operations at New York Presbyterian's emergency medicine residency, and she's also a member of the Coding and Nomenclature Advisory Committee for ACEP. So thank you to both of us for joining us on this webinar. Really excited to have you and to get the conversation started. Dr. Corrado, I'll start with you. What is the medical decision-making part of the chart, and why is it critical to the practice and charting of emergency medicine?
So it's a little bit self-evident. The medical decision-making part is the part typically, kind of at the end of your chart, which describes your thought process and what you had in your brain as you were taking care of the patient. To kind of back up just a bit, as I've said to you and Danny in the past, one of the most important things to keep in mind when you're writing a chart is or when you're writing anything for that matter, is who are your readers. Anytime you write something, you have to have your readers in mind. So when you're, I think a lot of, students and junior residents, and rightly so, are mostly, almost entirely concerned with the sort of clinical aspect of what you're doing, kind of explaining clinically what I'm thinking and why what I'm doing from a clinical perspective matters. But in fact, when you're considering who's going to be reading your chart, there's three kind of entities that I like to think of that are going to be in the future, potentially reading your chart. And as we've done at our place, we've kind of given them funny little nicknames. We've called them Doc, Justice, and Bill. So Doc is the idea behind writing for Doc is you are explaining to future or other clinicians who are going to be taking care of this patient the medicine, kind of your clinical thoughts and why you did this or that. Then there's Justice, and you need to write your chart in such a way that if it becomes the subject of a medical malpractice litigation, which will happen to almost all of us in this field if we stick around long enough, you need to write your chart in such a way that what you did is defensible and explainable to people who don't have the medical training that Doc might have. And then finally, you're writing for Bill. And the idea of this is the coders and the payers who are going to read your chart and determine how much money you need to be paid, you are entitled to be paid for what you've done. So the medical, sort of a long-winded kind of preamble, but the medical decision making is the section of your chart which explains your synthesis of the data that you've chosen to gather, explains your differential diagnosis, explains why you think this patient might have this, that, or the other, and what you're going to do about it. And the way you write it has to be intelligible to future clinicians who are going to be taking care of the patient. What were they thinking? What were you thinking? Has to be intelligible to the billers and the coders who can look at it and say, okay, this is how much money this visit is worth. And it has to be intelligible to lay people who are involved in your medical malpractice suit when this case has a bad outcome.
Thank you, Dr. Corrado. And that's really how I sort of frame my MDM as well. Especially, so I'll like my sort of perspective on it in my practices. I'll just write it as I normally write it. Then when I have a second, I take a look back and I say, does this hit all three major marks of conveying everything adequately to the medical professionals who are going to read this, to the coders and payers that one day I'll be responsible for as a resident, and then, God forbid, to the lawyers, expert witnesses, jurors, and whoever else may access the chart, patients now too. Dr. Hausner, what to you constitutes a good MDM in your experience so far?
Yeah, I think a good MDM gives a nice summary of the patient, why they're there, and your initial impressions. Um, so, you know, the 84-year-old female with coronary artery disease who's there for substernal chest pain, you may say, on initial exam, is well appearing, not diaphoretic, and no distress. And her EKG is normal sinus rhythm with no ST elevations or depressions. And you start out with a good summary and address the reason that they're there, and then go into differential includes and why things are higher on your differential or lower. May say, I think acute coronary syndrome is high on my differential, given her story of substernal chest pain and her comorbidities of age and coronary artery disease, and maybe she has diabetes and hypertension. And so what I'm going to do is get serial troponins and serial EKGs, and I'm going to give her an aspirin if she has chest pain. Then you may say, but less likely given that she doesn't have any chest pain anymore, or the chest pain was non-exertional, or you could say maybe it was relieved with exertion, which would be really unusual for ACS. And then you go through other differentials. Differential includes pneumonia because of this and that, less likely because of this and that, and how you're going to address those things. Making sure to include what labs you're going to do, what radiology you're going to do, and what treatments you're going to do. And then I try to include something about my interval of reassessment. So patients who are very ill, I will say that this patient is on a monitor, continuous monitor, and pulse oximetry, and will require frequent reassessments. Or I may say overall is well appearing. Their disposition will depend on their final labs and a reassessment.
Perfect. Yeah, I sort of have the same approach to it, and I like the way you laid that out. It should be a nice, easy read for somebody, and it should be a rational read, right? And the way I like to teach it is it should be stepwise in your approach, sort of what I initially saw, what relevant background information from the medical history review systems I'm gathering, and really what the thing I'm concerned about primarily is, and some other things I'm testing or not testing alternatively, just to say, like, this is what I do and do not think is going on. I just want to open it up to the audience. I know we have quite a few members here today. You can either turn your camera on and chat us, or just throw something in the chat if there's questions. I do have a set of questions already for the facilitators we can go through if you'd like as well. But this session's really for you all that are here in the audience. So if there's a burning question you have for Drs. Hausner or Corrado, just let us know.
Hi, thank you. I did have one question actually. So I'm a new resident. I'm just starting, EM internship. Thank you. And so one question I have is when I'm doing the MDM, sometimes I use sort of like ACS. I use like acronyms, and I sometimes don't always like write in full sentences. I'm wondering how beneficial is that, or is that okay, or is that sort of frowned upon?
At least from a coding perspective, that is okay. To use commonly used acronyms. The coders do know the language. So you can say ACS and they know that that's acute coronary syndrome. If you get into kind of making up your own acronyms, then of course, then it becomes less likely. But some will say like status post and they put like an S/P, things like that, the coders are familiar with. So at least from a coding standpoint, that's just fine.
Okay, thank you.
No problem. Thank you. And congrats on starting your residency. I would also agree with that. I would say, certain things, just using our institutions, for example, and I think most New York City places, just as an example, we use a terminology for psychiatric patients called EDP. Some folks will throw that in the MDM, like, patient is a EDP, blah, 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 blah. That's not necessarily like a nationally accepted vernacular acronym that's used like elsewhere, just using this as a particular example. So if it's something that is used routinely throughout the EM world, and any other medical professional that's going to be reading it will understand it, that's usually my gauge to use it within the chart. So like ACS is perfectly acceptable, but EDP, for example, like emotionally disturbed person, that's really sort of like a New York City centric thing, and that would be something I would exclude from the chart, and instead I would use like person has significant psychiatric history or certain something along those lines. That way it's a little more easily accessible for other medical professionals. Sort of going off of that question though, and that was a great question, Dr. Oates, thank you. Dr. Corrado and Hausner, I'd like to hear both your opinions on this, but what are some common mistakes in your experience by EM residents, in particular newer EM residents, when documenting an MDM, and sort of how could they be avoided in some stuff you've seen?
I would say there's a couple of things that I notice kind of consistently. One is that if you either overtly speak about something in your HPI, or recount something that a patient said or complained of, or kind of hint at it and kind of sniff around it. The patient recently took a long plane ride from Australia and she's on OCPs and she smokes, etc. If there's something in your HPI that suggests a differential, it has to be addressed in your medical decision making. You can't just let it hang there. And that's not to say that everything that's on your differential needs to have a test or a objective datum to, exclude it. But you have to address it. I don't think that this is a pulmonary embolism in this case, despite the above mentioned risk factors, because she was punched in the chest and has a bruise there, and I think that's the cause of her chest pain, something like that. So that's probably the biggest thing, is that if you read through the chart, if there's something suggested as part of your differential, you have to somehow address it in your MDM. And the second thing I would say, and this is probably just a bit of an idiosyncratic pet peeve of mine, but I do have a reason for my opinion. I see a lot of times residents, kind of like what you were, or I think what Danny was speaking about before, you'll start your MDM with a recapitulation of the patient. This 47-year-old male who has a history of hyperlipidemia and hypertension, blah, 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 blah. To my mind, that's kind of a waste of your time and keystrokes, because there's no need to recapitulate what you've already said, presumably to start your HPI. It's all part of the same document. So again, I don't want to say that like this is best practice or whatever. This is just kind of like something that I've noticed that just personally I find to be a little bit wasteful. I don't think that you necessarily need to rephrase your HPI down in the medical decision-making part. But curious what you and Danny think.
Yeah, I think so the reason I would say to include some of that information is particularly with the new CPT coding guidelines that are coming out, that have come out, that you do need to be explicit in why something is on your differential and why that patient is at risk for it and what you're doing for it. As it's not enough to list in the HPI that the person has hypertension, coronary artery disease, and diabetes, and then to list ACS as a differential, that you have to be explicit and say that they are high risk for ACS due to. Otherwise, your chart may be downcoded, which is why I do try to buff up the MDM a little more.
That's a good point, Danny. And just to kind of like back up for, the students and junior residents who are here, talking about the CPT coding, we could talk for hours about how your charts are coded and how the payers decide that, you know, when you take care of a person who's spraining their ankle, you get paid $60, whereas if you take care of a person with flash pulmonary edema, who you BiPAP this, that, you get paid, you know, $250. We could talk for a long time about kind of what goes into that. But the kind of like the big current news is that up until this year, the way that that was decided was a combination of what you wrote in your HPI, your review of systems, your physical exam, and your medical decision making. And there was a very particular point system that you had to kind of meet in each of those domains in order for your chart to meet a certain level. You've heard of charts called like level 1, 2, 3, 4, or 5, which are the corresponding CPT sort of levels. This year, which will go into effect, I think, in January of 24 now, that has been completely changed. And this is not a minor revision. This is something that happens once in decades. This is like a really major earth-shifting kind of thing in the way that we're paid, which is kind of why why Mike planned this webinar today. It's now entirely down to your medical decision making. You still have to do the appropriate documentation for your HPI and your exam, et cetera. But you're no longer, achieving points for examining, 8 different body systems. And okay, we check that off. Now you just need to document what's relevant. But really, you're being paid now entirely based on your medical decision making. And the things that go into that, as Danny was just alluding to, are essentially 3 big buckets. One is the number of things that you're thinking of on your differential and how complicated or potentially serious they are. The second is the number of data points that you review. In other words, if you're ordering x-rays, lab work, you're reviewing the EMS chart, you're looking at old medical records. And then the third thing is the potential risk involved in what you're thinking about. So somebody who, if you're ruling them out for stroke, and that's on your differential, that's obviously going to be worth a lot more than if you're ruling them out for a dislocated toe. So those are the 3 big buckets. So that's why it's now critically important that you document as carefully and as much detail as possible in the MDM, because this is now the only thing that is determining what you get paid. It's kind of, you can imagine being a waiter. This is your version of writing down what you brought the person. You can bring them, a steak and a bottle of wine, but if you only remember to write down the steak, then you gave them the wine for free. So it's important that you kind of write all of these things down.
Thank you. Sorry, guys, I'm working on my iPad, so I'm like typing at the same time, responding to people and unmuting myself. So this seems like a lot, and I appreciate both your insights in this. So, as far as documentation strategies for new residents in particular, and for any of the medical students that are in here for next year, do either of you utilize like any dot phrases or sort of a checklist when you're making an MDM just to make sure you're hitting all the key elements? Or did you start out that way and now it's just second nature to you? Like for me, for example, I have a very clear flow I follow for every patient. And that's sort of a flow for ESI 1s through 3s and a flow for ESI 4s through 5s. So for me, it's sort of just second nature at this point. But at first, when I began using MDMs, I did have a checklist that I went through just to make sure, okay, I acknowledge any abnormal vital signs. I made sure my HPI sort of dovetailed into my MDM, so there wasn't something that was, mentioned in the HPI that was critical that was ignored in the MDM. So just curious, both of your thoughts on approaching, and specifically start with Dr. Hausner, since you're still in the training period. Do you use a checklist, or for you, is it sort of like a second nature at this point?
I think it kind of feels a bit like second nature now, but I do follow the same flow each time, where I try to include my differential from what's most likely to what's least likely. And I try to say why or why not. I'm thinking this or that. And then I make sure that I say exactly what I'm going to do. Labs, imaging, treatment, followed by the reassessment interval. because sometimes, yeah, I do realize when I'm writing the MDM that, and I'm thinking of the differential, maybe I'll remember something like, oh yeah, I forgot this from the history, and I forgot to put that in the HPI, and then I'll go put it back in the HPI. Not as for a coding perspective, but more so from a storytelling perspective. So that would be in like talking to Doc, to make sure that the whole story is there.
And Dr. Corrado, since you, another hat Dr. Corrado wears, which I forgot to mention at the beginning, is he's one of our directors for our emergency medicine sub-internship. When you're teaching students, do you advise them to use a checklist, or do you just sort of go over the general themes of how to craft an MDM? This is sort of more so a question too for senior residents that are in the chat here that are now, in a new role of teaching juniors and reviewing charts and all that sort of stuff.
We sort of try to mirror what high-performing departments kind of do. And by that I mean a high-performing department is going to give you the tools and set up your EMR in such a way that really makes it, difficult to do a lousy job, I guess. So, with our sub-Is, we kind of use an acronym that kind of prompts them for the things that they need to document. But to get at sort of the heart of your question, I think, and this is a lousy answer, I'm sorry, but it's like so many other things that as you gain experience and do it more, it does become something of second nature. So I actually don't have a great answer or great advice on whether or not it's good for junior residents and students to create sort of a macro that prompts them to remember things, because cases really are not at least in emergency, actually specifically in emergency medicine, our cases are not conducive to using kind of the same rubric and heuristic for sort of every case. If you're working in ortho clinic or something, like, yes, it's conducive to that. But just think about the difference in your MDM section in somebody who like I was talking about before, comes in and flash pulmonary edema, and you're giving nitrates and BiPAP. A lot of it is if-then sort of decisions. If their mental status stays okay and the sublingual nitroglycerin relieves their symptoms, then we do this. If their mental status deteriorates, then we intubate. So contrast that with somebody who comes in with shoulder dislocation or gastroenteritis or something. So it's sort of our business. It's kind of difficult to come up with a specific rubric for every case, which it makes it tough on junior residents and students. But I mean, look, it's a hard specialty.
Yeah, I would also agree, since you touched on it. MDM, I use a lot of macros and I use a lot of dot phrases. MDM is actually one of the few places that I do take my time to actually dictate individualized to all patients, excluding some like very basic things, like if I'm doing urgent care shifts and it's like I don't know, trephination of a nail bed or something like that. Like that doesn't need much of an MDM, for example. We did have a question in the chat, which I wanted to address, and thank you for asking a question. It was from Dr. Burnett. Limited experience in the ED. To be clear, the system is shifting towards risk stratifying patients based on evidence-based medicine and clinical reasoning. I would say yes, in particular for what's required for billing. So for billing, yes, it's you need to explain your risk stratification, your reasoning in a little more detail than we used to have to do. For example, the old way you can just chart differential ACS versus pneumonia versus musculoskeletal discomfort. Now, to get the appropriate billing, sort of maximizing your chart, you have to say, differential includes acute coronary syndrome. And then this is the way I do it, for example. Acute coronary syndrome, parentheses, patient, long-term smoker, history of prior CAD, states it feels like prior MI, and parentheses, less likely pneumonia, parentheses, no fever, no sick contacts, vaccinated for XYZ, low, risk in this regard. So that's how I sort of do my quick bullets justifying why or why not something is high risk or low risk in my differential. That being said, though, you're still responsible for your other medical professionals that are going to be reading the chart, as well as the legal responsibilities in the United States for what you may be compared to for your peers. So, there are certain aspects of it that still need to be included. A lot of this is auto-generated by the EMR already. So, for example, Epic. It's always important to say that your nursing notes were reviewed, vital signs were reviewed. You can already preset these to say checked off in Epic, and that would necessarily satisfy like a legal requirement that's important. Also, like, ethically for the patient that you're reviewing nursing notes and in discussion with nurses if there's changes, but doesn't necessarily impact the billing or reimbursement aspect of the MDM. I hope that sort of answered your question. And I don't know if Dr. Hausner or Dr. Kurata want to add to that or not. But I do think, sorry, Danny, you can go.
No, I was going to say, yeah, certainly from the billing and coding aspect, definitely more emphasis on risk management. You get more out of what you are, your clinical thinking. So this person who comes in with chest pain may have very high risk for ACS, but if their workup for ACS is normal and say they end up having, rhinovirus and their SpO2, their oxygen is normal all throughout, you send them home with no treatments whatsoever. You now get paid if you chart correctly by saying how you considered a life-threatening and life-altering medical condition because that person is very high risk for that. And maybe you even mention that they are at risk for a bacterial pneumonia, and why or why not you're going to start antibiotics. And even if you don't give antibiotics, your documentation of why you are not giving antibiotics, you get paid for. So these things contribute to the complexity of your MDM. And rather than just previously, perhaps your chart would read as a patient with chest pain and cough has rhinovirus. Maybe that's like ends up being like a level 4, meaning that it needs minimal input from a physician because there's nothing to do for rhinovirus. But actually, you spend a lot of time thinking about does this person need to be hospitalized? Do they need antibiotics? Do they need a cardiac consult? And now you get paid for that. Additionally, the old CPT guidelines used to include billing for time spent with the patient, and now that's only applicable to critical care. So because when we deliver critical care, it's usually in discrete time periods that you're spending 30 minutes of critical time, for example, with a patient, and then you move on once they're stabilized. But all the other patients you're seeing all together, rather than one after another. So it's nearly impossible to quantify how much time you're spending with a patient, and to have to go in between patients and back and forth is also more time consuming than if you were able to follow one patient from the beginning to the end, and then the next patient from the beginning to the end. So that was hopefully in the end, once we all get used to the new guidelines, that we can actually bill for what we are doing.
Sorry. Glad we answered your question, Dr. Burnett. Thank you for asking. I just sort of wanted to extend off this question a little bit too. Can both of you touch on a little bit the importance of considering higher risk diagnoses in the MDM and performing adequate testing to minimize or to mitigate potential liability? I feel like there's two, and let me clarify that a little bit with some examples. I feel like there's two schools of thought on how to include high risk diagnoses in the MDM, and it's either you do or you don't at all. For example, aortic dissection, like a patient may come in with chest pain radiating to the back. Your really highest pretest probability for the patient is acute coronary syndrome. You do not think it is an aortic dissection. Some folks will decide to include in their medical decision-making differential aortic dissection, and then we'll say, less likely on my differential because, equal pulses in upper extremity, patient resting comfortably, or some folks may not include it at all because they're like, if I put it in my MDM, I have to test for it, and I don't want to test for it. But I do think it's sometimes important to say why or why not this isn't a dissection. So, I just want both your thoughts, and then I'll end with my thoughts on the idea of putting that in the MDM.
So, it's a great question. you are allowed, you know, legally speaking, ethically speaking, etc., mostly legally speaking, you're allowed to be wrong. You are allowed to have a bad outcome, to miss a diagnosis. What you're not allowed to do is to have not thought of it. You know, the legal system puts a tremendous amount of faith in your professional judgment. So, you know, and by the way, none of this comes into play unless you were wrong and the person who you didn't think was dissecting and then they died or had some really bad outcome. So if you're always right, then it doesn't even matter. But over the course of your career, you're going to be wrong a few times. So your general approach needs to be kind of the first thing that you said. You have to mention it because you must demonstrate that you thought of it. Not everything that you think of requires a test. It is absolutely valid to say, yes, I acknowledge that, you know, chest pain radiating to the back can be consistent with aortic dissection, but I've reasonably excluded that because, you know, like you said, equal pulses, this, that, you know, you can say, I thought of it, and here's why I am choosing not to do a test. And that's perfectly okay. And if the person ends up with, you know, dead from a dissection that you missed, are you guaranteed to be off the hook? No, but you are much, much, much better off than had you not written anything, because then the question is, have you ever heard of a aortic dissection? What symptoms are consistent with an aortic dissection? Did you think of that? Because it doesn't seem like you thought of it because you didn't write anything about it. And, you know, your goose is really cooked in that regard.
Dr. Hausner, your thoughts on that sort of topic?
Yeah, I mean, I would have to agree with Dr. Corrado. It does feel a little bit bad to put it in the MDM and then not order a test for it. But if you can explain why you don't think that is what it is, then I think that's just fine.
You know, this is how we define standard of care. Standard of care essentially is what would most other competent normal physicians do in this situation. So if, you know, if you consider dissection because they complain of, you know, chest and back pain, but you then realize that the time, the cost, the radiation, the contrast load, all of these things make it make the balance between getting the test and not getting the test in favor of not getting the test because you've reasonably excluded it on clinical grounds. If most physicians would do that, then an expert witness is going to be very hard pressed to say that, like, well, you know, no, most people would have gotten the test. You just have to explain why you're making the judgment. You're allowed to use your judgment. It's what we get paid for.
Thank you, guys. And I actually agree. I mention it in my MDM. I don't do, you know, one thing I always comment on when I'm giving advice to junior residents or doing chart reviews or anything like that. I personally don't do, I know some people have a dot phrase for all chest pain comers, for example, and it'll just, you know, they'll do their normal MDM and then at the end it'll be thought of or recognize the potential for the following serious diagnoses and low clinical suspicion based off exam. And it's like everything that could kill the patient in the chest. I personally think that's a little bit overkill. I do think it's pertinent to, you know, go based off what the patient's story and the clinical picture is. Essentially, like my rule of thumb that I tell learners is, you know, if someone looks at this chart and they're going to ask you, did you think of PE or did you think of aortic dissection? And you really don't think it is, and you didn't include it anywhere in your MDM, you should probably include it in your MDM. Because the reality is, like, people are going to look at the chart and they're going to say, did this person think of this? You know, it's going to be the medicine team, the ICU team, whoever, you know, the family med doctor that's going to be following up on them afterwards if they're having persistent symptoms. You know, there's a lot that goes into charting, particularly for these common but serious diagnoses. So I would definitely like at least have some little blurb about it in the chart. So just to wrap up here, I just wanted to end, see if, number one, anybody has any more questions. I can either, again, ask here or ask in the chat. If not, I just want to give, you know, Dr. Hausner and Dr. Corrado a chance for like final one pearl to take away from that you think every ER resident should know for their MDM charting, or one tip of advice, one piece of advice. It could be a pitfall to avoid, it could be a pearl. And of course, if you're still here and you want to ask a question, the chat is open and I'm reading it.
I try to think, if somebody else read my chart, would it make sense? would it make sense from the HPI down through the MDM that what I said is happening based on what my exam was? Does it make sense, the differential that I gave and the interventions that I took? And actually, in thinking of putting kind of deadly diagnoses and not working them up, reminds me of a case that I got signed out of, neck pain and chest pain and arm tingling. And I wondered, I said, why are we not asking if this is like a neck dissection? And when I finally went and talked to the patient, it was very clear why this was not a dissection, like a vessel dissection, because it was clearly musculoskeletal pain that they've had for years in the back of their neck, not in the front. And the numbness occurred only after, laying on their arm 3 days ago. The story, but the story wasn't told. And so when I got this patient, I thought, whoa, this reads like we need to be getting a CT angio of his neck. And then I just documented it as such. No concern for carotid or vertebral artery dissection because of this and that and that.
I can add a pearl. Not that this is necessarily the most important thing, but it's just a pearl. Write your MDM with the following presumptions. One is that there's going to be a bad outcome. It's going to be something that you've missed, and the patient's not going to do well, and you're not going to know about this for until two years from now. So you're going to have no recollection of the case whatsoever, but it went bad. So does your MDM stand on its own as a defense of the care that you provided? In other words, could you look at this MDM with no recollection whatsoever of the case and read through it and say, like, yes, this is what I was thinking. This is why we did this. This is why we didn't do this. Can this defend the care that you provided? Presumably, you are comfortable and happy with the care you're providing and you feel good about it. And just make sure that your MDM is able to stand on its own and defend what you did. It's really, and look, you got, this is like the story of our lives in this business. It's easy to talk about that in isolation on one case. But you guys are seeing 20, 25 cases in a shift, and you're doing 5 shifts a week, and typing in the computer is so much less important, feels so much less important than actually taking care of the patients. But what ends up happening when there's a problem and you're the subject of an M&M or a lawsuit, no one cares what else you were doing. It is all you've got is you and your chart for that patient. So it's sounds like almost an impossible mandate, but every chart you write ought to kind of have that level of kind of tightness in the MDM, such that if you read it 2 years later, it would be a perfect defense of why everything that you did and didn't do was the correct thing.
Thank you. I actually really like those pearls. And just to go over them again, Dr. Hausner really touched on make sure you're telling a story that makes sense for the case in front of you, such that any rational emergency physician or other provider can go there and say, okay, this is why they did what they did, and I understand this. And Dr. Corrado's point, which I also really like, is make sure that MDM stands on its own. We always like to talk about lawsuits, but even just like basic departmental QA and QI, like there's sometimes a chart will get pulled for a reason, and I'm like, I don't remember this one. And then I read my MDM and I'm like, oh, okay, now I remember. Make sure it can stand on its own. Make sure you're writing it enough such that you could say, okay, a year from now, 2 years from now, I'll be able to say, okay, I have some recollection of this case at last. My final pearl would be more so from an education perspective. Find a group of mentors, of EM physicians, residents that you really like, that you think do a good job, that you want to model yourself after, and take a look at their charts. Read their charts, read their MDM, see what they chart, see what they think is important in MDM, and sort of, I feel like charting gets downplayed a lot in residency. We focus a lot on the clinical aspect, but when you're in attending, this stuff becomes really important, for your livelihood as well as for, legal responsibility. And I think it's important to find good mentors in that aspect as well. Thanks again to the SAEM staff for hosting us today, to all of you for joining us on a Thursday night. Thanks again to Dr. Hausner and Dr. Corrado. Any final words or anything like that? I'm Mike DiFilippo again. I left my email in the chat. I have some notes I can send out to some folks if they want like a little cheat sheet to give or to have on shift to save on their phone as like a PDF. I'd be more than happy to share that. And thanks again, everybody, for coming today.
Thanks, Mike.
Thanks for having me.
Thanks, Juana. Bye, guys.
Bye, everyone. Have a great day.